Thank you for joining us. We're going to get started in just a couple of minutes.
Good afternoon, everyone, and welcome to Overcoming Disparities in African American Infant and Maternal Mortality, the prequel, Black Infertility. I'm Dr. Sylvia Swilley, Chair of the Association of Black Women Physicians, African American Infant and Maternal Mortality, AAIMM, Working Group. For the past 2 years, ABWP has co-sponsored a series of webinars with some of the Department of Public Health AAIMM stakeholders, devoted to addressing the disparities in morbidity and mortality for African American infants who die at twice the rate of white infants, and Black mothers who die at 3 to 5 times the rate of white mothers in the first year of life. The previous webinars addressed racism as a root cause, social determinants, preeclampsia, prematurity, maternal mental health and midwifery, as well as the role of doulas. These webinars are available for review at the link noted in the chat. Though all the previous webinars were open to the general public, the audience was primarily professionals and those engaged in pregnancy work and related fields. Because of the lack of knowledge about infertility in Black women and the need to advocate for ourselves, we thought it important to encourage a wider audience for today's presentation. We again partnered with the Charles R. Drew Black Maternal Health Center of Excellence under the co-directorship of Dr. Brandy Sims DesJarlais. Dr. Sims DesJarlais.
Thank you, Dr. Swilley. We're very grateful for the partnership of the Association of Black Women Physicians, the AAIMM Initiative, the March of Dimes, PACLAC, and the California Healthcare Foundation on this webinar. The Black Maternal Health Center of Excellence is grounded in Black reproductive justice. An essential part of that is really ensuring that Black families are able to have the children that they want to have. In my research, a reoccurring theme that I've heard from Black women is their need to delay having children until they complete graduate school or achieve some other marker of professional or financial readiness. And the timing of that is often impacted by structural racism, or perhaps having difficulty finding a partner, getting pregnant, and then possibly having difficulty having a second child. And these challenges have been exacerbated by the pandemic. The National Bureau of Economic Research just released a paper showing that while white, Hispanic, and Asian women have experienced a baby bump during the pandemic, Black women actually had a decline in birth rates, accounting for almost 23,000 missing Black babies. While we can't attribute this decline to infertility, we know that Black women are overrepresented in essential and frontline roles and have faced significant financial, physical, and mental challenges during the pandemic, which can make delaying pregnancy seem a prudent choice, without realizing that according to the CDC, Black women are more likely to be infertile than white women, while also being less likely to have access to fertility treatment. We hope that this session provides much needed information on infertility that can support both the decision-making of Black families and their care by providers. So we want to thank you all for being with us here today. And I'm going to hand it back to you, Dr. Swilley.
Thank you, thank you. I must say that I was surprised and admittedly embarrassed when Dr. Sims suggested infertility as a topic, as I did not realize that Black women were disparately impacted by infertility. Medical articles have also documented that not only are Black women less informed than non-Hispanic white women on the subject, but that this basic lack of knowledge extends to medical professionals. We have all been exposed to the same historical trope about the hypersexual, hyperfertile Black woman. Today, we set the record straight. The format for today's workshop will be presentations by our guest faculty, followed by a moderated panel discussion. Please put your questions in the Q&A rather than the chat. The Q&A will be monitored and the questions fed to our faculty during the panel discussion. Our first presenter is Dr. Samantha Butts. Dr. Butts is boarded in obstetrics and gynecology and the sub-board of reproductive endocrinology and infertility, REI. After 15 years at the University of Pennsylvania, she moved to the Penn State College of Medicine and Penn State Health, where she is professor in OB and the chief of the Division of Reproductive Endocrinology and Infertility. She is on the board of directors for the Society of Reproductive Endocrinology and Infertility and is an associate editor of the Fertility and Sterility Journal. The chronicle of her appointments, awards, honors, memberships, editorial positions, academic and institutional committees and teaching positions, lectures and bibliography required 2 reloads of paper for my printer and 1 ink cartridge change. She is quite prolific. We are so privileged to have Dr. Butts present to us today on infertility, causes, evaluation, and disparities. As with all of our previous webinars, we have always included a mother who can share the lived experience, making clear that the topics we select are not theoretical, abstract, or just content for academic discussion, but reflect a painful reality for many. Ms. Regina Townsend, founder and executive director of the Broken Brown Egg nonprofit, not only shares her personal experience, but her blog, pioneering work in Black infertility advocacy, and writings have benefited an international audience of thousands. She continues to work as a librarian, no doubt making use of her research science training to produce her book, Make If Make Sense. I won't say more about her book, its title, and her organization, as it's best to hear it in her own words. But lest she be modest, I do want to mention that her writings have appeared in the New York Times, The Atlantic, USA Today, and Slate, and she has been honored as one of the best bloggers of 2020. The final presenter is Dr. Desiree McCarthy-Keith. As a board-certified obstetrician gynecologist specializing in reproductive endocrinology and infertility, Dr. McCarthy-Keith has a wealth of experience in evaluating and treating patients with a variety of modalities. During her fellowship, she focused on the molecular mechanisms of uterine fibroid regulation and reproductive health disparities. She has special interests in both male and female infertility, polycystic ovary syndrome, fibroids, and in vitro fertilization. She has authored several peer-reviewed publications on reproductive and infertility topics and has presented her research nationally. After a stint as a lieutenant commander in the U.S. Public Health Service, Dr. McCarthy-Keith joined Shady Grove Fertility in Atlanta, where she is the chief medical director and the first African-American partner and board member of this nationally recognized fertility treatment center. Dr. McCarthy-Keith is passionate about her vegan way of life and encourages her patients to incorporate a healthy diet in their fertility journey. Today, Dr. McCarthy-Keith will focus on infertility treatments, therapies, and outcomes. Our moderator today is Dr. Kimberly Gregory. Dr. Gregory, boarded in OBGYN and maternal and fetal health, is a professor in OBGYN at UCLA and the director of the Division of Maternal Fetal Medicine at Cedars-Sinai Medical Center. The diversity of the subjects addressed in her extensive bibliography attests to the breadth of her knowledge and curiosity about the broad area of maternal and fetal well-being. Dr. Gregory has secured an impressive reputation in the world of reproductive justice and is vice chair of Women's Healthcare Quality and Performance Improvement in the Department of OBGYN. She has been awarded with numerous honors and was bestowed the second Miriam Jacobs Helping Hand Endowed Chair in 2018. She is one of ABWP's own, as she received our Rebecca Lee Crumpler Scholarship during her medical school training. She is the past president of ABWP and serves on ABWP's AIM working group. She needs no introduction or welcome, as she is one of us. To ensure that we will have enough time for questions and a robust discussion during the Q&A, we will hold our presenters to their allotted times. So let's get started. Dr. Butts.
Thank you, Dr. Swilley. That was an incredibly generous introduction, and I'm going to strive to make you very proud in my comments and presentation. So I'm going to share my slides. Okay. So I just want to take an opportunity to express my gratitude to Dr. Swilley for inviting me to participate in this webinar, and acknowledge all the organizers and stakeholders, the Drew Black Maternal Health Center of Excellence, the Association of Black Women Physicians, and all the stakeholders, and really also express how humbled and honored I am to be on a panel of such esteemed and accomplished women in medicine, research, and clinical care. I have a disclosure slide, which is that I am on the Ferring Pharmaceuticals Diversity, Equity, and Inclusion Board, but I am not discussing any products or pharmaceuticals in my presentation. And I'm actually going to start my presentation with a question, which is, what is a reproductive health plan? I would imagine that some of the presenters and some of the participants on this call have thought about this with patients and have talked it out, but it's probably not something that's as routinely addressed as it should be. When I think about a reproductive health plan with patients, it encompasses several facets, including a discussion with the provider that occurs on a regular basis, addressing the intention to become pregnant, whether patients wish to become pregnant in the future or do not. Any perceived barriers to pregnancy that the patient has themselves or their provider has, what the contraceptive needs are so that women and individuals and couples can become pregnant when they want to, but prevent pregnancy when they don't wish to become pregnant, and also preconception health. This is incredibly critical in terms of thinking about issues that are very, very front of mind for all of us now, including maternal morbidity and mortality for women of color, and also how preconception health affects fertility success and likelihood of becoming pregnant for some women. I'm going to reference here an outstanding a piece of data from the American Society of Reproductive Medicine and the American College of OBGYN. This is a committee opinion. I think it's about 3 years old. It's incredibly pertinent and relevant. It's on pre-pregnancy counseling. This is a busy slide. I have a link to this document in my references and happy to share it at any point, but really the meat of this document gets into what we should be talking to patients about before they even become pregnant. Now, we don't always have the luxury of having that conversation. And one of the things I tell my patients is, if there's a silver lining to be had by having to come see somebody like me, is that it forces us to have these conversations because we're doing an infertility workup. And we also have to talk about the kinds of health indicators that can affect the likelihood of becoming pregnant and risks to moms and babies in pregnancy. I'd like to highlight a couple of things, including the fact that we should be counseling women to always seek care before they attempt to become pregnant. And this is going to come up in some of the later slides that I discuss and that I think some of my co-panelists will discuss as well, which is what a lot of Black women are discussing as challenges in their interfacing with healthcare providers, is that the focus is always on preventing pregnancy and contraception and not having a robust, thorough conversation about what are your goals and how can we make you as healthy for pregnancy as possible. A number of chronic medical conditions that can be prevalent in our communities, including diabetes, hypertension, and things like that, have implications for pregnancy and should be optimized before people get pregnant. along those same lines, the medications that treat and address these conditions need to be considered, because not all of these medications are safe in pregnancy, as they can be harmful to a developing fetus. And those are the kind of things that should be known and addressed prior to becoming pregnant. We should always have conversations about screening for infectious conditions, optimizing immunizations. What's not on this list, because this was a document that was published pre-pandemic, but encouraging our patients to become vaccinated against COVID. It is recommended and safe to do for women who wish to become pregnant. I want to push back against any of the false information out there that suggests that becoming vaccinated against COVID affects your fertility, and other things, varicella, chickenpox, rubella. All of those things can impact congenital developmental problems in infants if women are not immunized against them. We should be having conversations with patients about what is safe dietary choices in pregnancy, avoiding alcohol and nicotine and drugs in pregnancy. There's a lot of things around drug use, like marijuana use, and whether or not that is negatively impacts fertility, even though a lot of people are using it for other health indications. And we should have those conversations and individualize the care. In addition to medications, vitamins and supplements should also be discussed, as should safe and healthy body mass index and weight for all patients. I want to next shift gears and talk a little bit about definitions and what do we mean when we're talking about infertility, because I feel like this is also something that should be clarified in our minds when we're counseling patients, and making sure that we are not allowing patients to miss out on opportunities to have evaluations. In general, the definition of infertility is the inability to conceive after 1 year of unprotected intercourse. But this is conditional on a number of things. Number one, conditional on the age of the female partner. If you are 35 years or older and you've been trying for 6 months and not achieved a pregnancy, we think you should have a consultation with a fertility specialist or start an evaluation for pregnancy. We should also individualize and consider certain gynecologic and medical problems that may impact the ability to become pregnant, and we shouldn't necessarily apply definitions of infertility to people who have pre-existing gynecologic problems and make them try for a year if we already know that the deck is stacked against them. And this includes women who have irregular periods for a variety of reasons, things like polycystic ovary syndrome, thyroid disease, uterine fibroids, which I'll get into a little bit more in a moment, endometriosis, and fibroids and endometriosis are prevalent, common things in women generally. Fibroids, as I'll talk about a little bit more, particularly prevalent in African-American women, but endometriosis is a common cause of chronic pelvic pain that can also impact fertility and is prevalent in up to about 10% of women. Any woman who has had a history of an ectopic pregnancy should not try for a year before seeking an evaluation. And I would argue that if you have that history, you should talk to a provider and or specifically a fertility specialist before you ever try again, because of the risk of having a recurrent ectopic pregnancy and barriers to fertility. Patients who have had gynecologic surgery should have a discussion about what the nature of those gynecologic surgeries were and how they might impact fertility. Any prior pregnancy complications, and I know that this will resonate with Dr. Gregory, who's our maternal fetal medicine specialist. There's an opportunity to have pre-pregnancy consultations, not just with fertility specialists, but with maternal fetal medicine specialists to reduce the likelihood and mitigate risks of pregnancy complications as well. And I'll just quickly wrap up by saying patients who have had serious diagnoses like cancer or other conditions for which they were prescribed medications to save their lives can sometimes impact and damage the ovaries. And those kind of conversations should be had early and often when fertility is front of mind for them. When we're talking about the prevalence of infertility and causes, I'm not going to get into treatment so much because Dr. McCarthy-Keith is going to focus on that. But infertility is probably more prevalent than a lot of people think. Estimates currently are that 10 to 15% of couples are affected. The National Survey of Family Growth, which is a national survey performed every several years under the auspices of the Centers for Disease Control. One of the most recent iterations of the survey suggested that 12.7% of women ages 15 to 49 had ever used an infertility service in this country. I've listed here some of the treatments that we offer. As I said, I'm going to defer to Dr. McCarthy-Keith to talk about that more. But looking at the pie graphs on the left breaks down what a number of the common causes for infertility are. The first pie graph focuses on causes in women. And up to 40% of the time, there is a problem with ovulation, preventing or reducing the likelihood that women will become pregnant. As I mentioned before, one of the most common causes of this is polycystic ovary syndrome, which affects anywhere from 10 to 15% of women. Unexplained infertility occurs when we have done all the high-level assessments of male and female partners and haven't found a identifiable cause. That doesn't mean that treatments can't and shouldn't be offered. And tubal and pelvic pathology, this encompasses a number of conditions, including blocked or damaged fallopian tubes because of prior sexually transmitted infections, prior surgeries. Uterine fibroids can also make an impact, although the impact is a little less straightforward than frank tubal disease, and I'll talk about that a little bit more in a minute. The second pie graph drills down on the causes of infertility in couples, and I really want to call this out. 35 to 40% of the time, there is a male factor that is the leading cause or a cause in combination with female factors. So this means, and I tell my patients this all the time, a sperm analysis is one of the most high yield assessments for fertility that we offer to couples. And I think that has to be driven home often and over again. So this is a schematic of what a normal uterus looks like on the right and what a uterus with fibroids looks like on the left, and what a uterus with fibroids looks like on the right. Fibroids are common in women. They are particularly common in African-American women. They essentially are growths that comprise muscular and connective tissue that grow in discrete circular bundles in the uterus. And as you can see here, they can be in lots of locations in the uterus, and the size and location really impacts or makes an influence on whether or not they are impacting fertility. The risk factors for fibroids, as I've suggested before, include African-American race, family history, and age, amongst others. We see some associations between fibroids and obesity, but that's a little bit less clear cut. And the fibroids that tend to impact pregnancy outcomes the most are the ones that are here inside the lining of the uterus, pushing into the lining of the uterus. Those are the kinds of fibroids that can significantly increase the risk of miscarriage and can increase the risk of pregnancy complications. And so I would add to the list that I mentioned before about ongoing medical problems that any woman who has a known history of fibroids has to be considered as a very special group. We should always be offering routine surveillance to them because the natural history of fibroids is to recur if they have been surgically removed. And that has to be considered in the fertility journey of any woman who has fibroids. I want to go a little bit more in depth into what do we do when we are evaluating individuals and couples for infertility. This is another outstanding document from the American Society for Reproductive Medicine and the American College of OBGYN that focuses on what is the workup. And what I like about this document is it's not just focusing on what people like me do, who are subspecialists in reproductive endocrinology, but it's the kind of evaluation that we can all think about and expedite for patients. On the female side of the equation, it starts with the basics, as all good medicine should. Getting a thorough history and physical, focusing on some of the things I just spoke about. a pre-pregnancy evaluation, as I said, which integrates primary care doctors, maternal fetal medicine specialists as indicated, and laboratory and radiologic evaluation to understand the endocrine indicators of reproductive potential and the anatomic indicators, including evaluating the size and contour of the uterus, looking for structural abnormalities like fibroids and polyps, evaluating the patency of the fallopian tubes with either X-ray or ultrasound-based modalities to see if tubes are open or blocked. And again, targeted evaluations of the uterus, not just with a standard transvaginal ultrasound, but with targeted modalities that drill down on the inside lining of the uterus, including hysteroscopy, HSG, and things like that. For the male, it really boils down primarily to the sperm analysis and a history as indicated, because sometimes a male partner will say, oh, I had leukemia as a child and I got chemotherapy. And so that changes things drastically in terms of what you're expecting you might see in a semen analysis and how you expedite the process for a couple. What's coming up next are tests that should not be routinely ordered, including laparoscopies for unexplained infertility, unless a patient has a longstanding history of severe dysmenorrhea, in which case we might think that they have endometriosis and that should be evaluated. Postcoital testing as a proxy for sperm has been essentially debunked as a reliable indicator of male factor assessment. And these other tests that I mentioned here, I won't elaborate on them for too much, but I'm happy to answer questions later on. I should also mention that the job of a reproductive endocrinologist is not just to evaluate heterosexual couples trying to become pregnant. We are in the business of helping all manner of individuals who want to engage in family building, fertility preservation, and procreative management to have an opportunity to be evaluated, assessed, and have their fertility goals met. And this includes single patients who want to think about future fertility planning and fertility preservation, whether that's cryopreserving eggs or embryos, members of our LGBTQ+ communities who essentially have to see people like me and Dr. McCarthy-Keith in order to become pregnant. I've alluded to people with a cancer diagnosis when we see them after the fact, but really we'd love to see them before they start cancer treatment so that we can have a conversation about fertility preservation, patients who are carriers for serious genetic conditions, and that includes patients who are carriers for sickle cell anemia, cystic fibrosis, and the management of conditions, whether that be medical or surgical, that can be associated with infertility. We've already touched on things like endometriosis and fibroids, but that is not an exhaustive list. I want to just speak briefly about this background slide because it's going to pertain to some of the next few slides that I talk about, and I've alluded to the National Survey of Family Growth previously. This is a survey conducted by the Centers for Disease Control, the goal of which is to gather information on pregnancy, births, marriage, cohabitation, infertility, and contraception. The survey has evolved in the last several years to be, I think, much more inclusive and modern in terms of not limiting these assessments to women who are married, but to understand the fertility experience of people regardless of marital experience, expanding the age ranges of people that we look at as well. And so this is a sort of graphical summary of what infertility and impaired fecundity have looked like over time. Starting back in the late 60s up until more current times. And just to give you a little bit more definition, because I gave you a very specific definition of infertility for the purposes of this survey. The CDC and the National Survey of Family Growth are defining infertility as the percentage of women 15 to 49 who have had 12 consecutive months of unprotected sexual intercourse without becoming pregnant. And impaired fecundity is any person 15 to 49 who has had difficulty becoming pregnant or carrying a pregnancy to term. In the most recent iteration of the survey, 2015 to 2017, you can see that, again, these are prevalent things occurring to women, regardless of marital status. It again debunks the myth that these are limited conditions that not many women suffer from. But this is a conversation about disparities. And so I want to take a moment to talk about what Dr. Swilley alluded to before, which is this notion, which debunks a lot of thoughts out there, that Black women either don't have infertility, and certainly reason to believe that Black women may experience infertility at higher rates than white women. In 2010, there was data that looked at this specifically, demonstrating that white women at that time experienced infertility 5.5% of the time, at least that's what the survey captured, and African-American women at 7.2% prevalence of infertility were 84% more likely to experience it, and Latina women were 43% more likely to experience it. And these proportions and differences were regardless of educational status, whether you had had a child before, income, and self-reported history of pelvic inflammatory disease. I do want to call out, though, that we should be looking at factors in combination and not just in isolation. And one of the things that the slide shows is that if you are African American, that the combination of educational attainment and race adds to the likelihood of having infertility, or describing that, such that 26% of women who were African American and had less than a bachelor's degree described having infertility. Another group of investigators looked at another very important survey, the National Health and Nutrition Examination Survey from 2013 to 2016, to ask the same question: does infertility vary according to race? And they used one of the survey questions, the only one that really addresses this, which is to say, have you attempted fertility for 1 year without becoming pregnant? And I'm going to highlight this because the type is a little bit small. As compared to the National Survey of Family Growth, you can see here, 13% of Black women reported infertility, 13.2% of white women reported infertility. So no significant difference in this survey. And I call that out just to say there's more than one way to look at this question, and more than one way to consider this. But I think what we're left with is the idea that certainly African American women do not suffer from infertility less, and they probably have comparable to higher rates of infertility. As pertains to the utilization of infertility services, right? Because we can say on the one hand, African-American women maybe have comparable to higher degrees of infertility. So one would then assume that they are using infertility services more. And as I said before, 12.7% of all women described in the National Survey of Family Growth that they had ever used infertility services, but let's see how this breaks according to race. And so, looking here and educational status, if we look at women who have less than a bachelor's degree, they are less likely to utilize infertility services, regardless of age. And, I think that this is telling us something very important about socioeconomic status and access to care. And then going back to the paper that I last talked to you about from the National Health and Nutrition Survey, while African-American women and white women, 13 and 13.2% prevalence of infertility, African-American women were far less likely to utilize infertility services. So 6.8% compared to 10.6. So here's where we start to see the disparity open up, because if you assume that African-American women are just as likely, if not more likely, to have infertility and they use services less, then this is where there is a real problem. So what might be driving some of this problem? Well, according to the New York Times and to those of us who know and practice in this space, infertility treatments are expensive, and the most effective for most women and the most costly is IVF. These numbers are probably giving some of you a little bit of sticker shock right now. But when we look at either IVF as a single time solution or looking at multiple times, because a lot of people need to do this more than once, it can cost people in the high, 5 digits up to 6 digits in order to achieve a pregnancy using these treatments. And I'll just wind down by talking a little bit about high costs on the one hand and infertility coverage by insurances on the other. Resolve is a national infertility association that's an advocacy organization, provides a wealth of information about these kind of things. And as you can see, any state with a yellow box, or that's colored yellow, offers some kind of infertility insurance mandate that involves either requiring employers to cover diagnosis or treatment. But I don't know about you, I was always taught to read the fine print. And since we are working with with a group of providers and participants in California, I thought I would just share what the California state mandate shows. And I want to focus on the exceptions. So one of the exceptions to the law is it only requires insurers to offer infertility treatment coverage. You don't have to give it to everybody. And this does not include IVF, which, as I mentioned, is the most effective treatment for most women. Religious organizations are exempt from having to cover this if they don't agree. And Medi-Cal and managed care health services are exempt from offering things like fertility preservation, which, as I mentioned before, is important for patients who may be getting cancer chemotherapy. And anyone who is self-insured is exempt from the law. One of the biggest employers that is self-insured in this country is Walmart. And as a result, if you work for Walmart, you don't have to have coverage. But I think that they just changed that and are starting to expand their coverage for employees. This shows up, and this has been explored and discussed by a number of investigators when we're looking at differences according to race and ethnicity in terms of not only who utilizes care, but how it introduces delays in care. This is hugely critical because we know not to traffic in fear mongering, but the more that you delay treatment, the less likely it is that treatment is going to work. And across the board, when people have published in the space, Black women are 12 to 15 months delayed compared to white women when it comes to pursuing infertility treatments. This also holds up for Hispanic and Asian women as well. This is another study that just supports that, but also looked at this in a state that had health insurance mandates. In other words, Illinois offers some of the most generous infertility coverage in the country, and still African-American patients were less likely to have access than their white counterparts. And then one of the last things I just want to focus on is I can present research papers about all this, but I think it's incredibly important that we talk to real people and patients and understand the lived experiences. And we're going to be addressing this shortly. But in this New York Times article published several years ago, people actually asked Black patients, what are some of the barriers that you identify? And they described the cost of treatments, as I've mentioned, social stigma and isolation of talking about infertility, and some of the things that we've got to own up to as doctors, including feeling dismissed by physicians and misperceptions, both by patients and by physicians, about who is affected with infertility. And this is not just a disease of white women, as I hope I've impressed upon you today. And I want to end with this slide, which is to say that, you should feel like you can get outstanding health care from any physician of any color at any time. But the fact of the matter is that a lot of patients have said that they feel more comfortable having these conversations with Black doctors. And I'm incredibly proud to be a Black reproductive endocrinologist. And I just want to share some of the beautiful faces of some of my colleagues across the country who are offering these services. And just want to thank you all for having me and participating in this incredibly important webinar. I'm going to stop my share. And I'll look forward to taking questions later on.
Okay, thank you, Dr. Butts, and we're just going to move right along to Miss Regina Townsend.
I'm over here clapping. I know you can't hear me, but so much of just what I stand on a soapbox about infertility about you covered. And so I just appreciate that, Dr. Sam. Thank you for that presentation. It was awesome. So let me see if I can share my screen. All right. So I hope you guys can see that. So as mentioned, I'm Regina Townsend. I am the founder and executive director of the Broken Brown Egg, which is an internationally recognized nonprofit that focuses on awareness, advocacy, and empowerment with an emphasis on the Black experience of infertility. So my disclosure is that I have been working with Ferring Pharmaceuticals as part of their patient advisory council, but none of that will be a part of my presentation today. I just following the trend of including the disclosure. So here's my journey. I was married relatively young at 23. I already had ridiculously lengthy periods that were lasting upwards of 30 days. They were driving me crazy, but also I was spending nights in the ER. I was not getting clear understanding of what these things meant. And I decided from that to look into what was going on because I wasn't getting very clear understanding from my doctors. I started the Broken Brown Egg to kind of express how I was feeling as a young person navigating infertility after never having heard that Black people experienced it at all. I remember I had been a part of a website called Chocolate Brides, which was a place for Black and brown people who were getting married to discuss the lack of representation of us in the bridal industry. And people would stay around because this was pre-Facebook and you were looking for community. And people would go from their wedding to buying a house to having a baby. And I saw a couple of women mention infertility or seeing a reproductive endocrinologist. And I remember thinking, wow, that's really interesting. I didn't know Black people dealt with that. And then it was out of sight, out of mind until it was affecting me. And then I realized that it wasn't just this anomaly that was happening to these couple of people, but that the more I started talking about it, the more I realized that it was affecting quite a few of us, but that not many of us were talking and there wasn't much representation. From having my blog and trying to connect with other people, I finally found a reproductive endocrinologist who actually found me through my blog and encouraged me to ask my doctors about polycystic ovary syndrome, which I had not heard much of before that. When I went to the doctor and told my new doctor that I was so excited to see, because I was like, finally, I have health insurance, I can go see somebody. And I told her, I think I might have PCOS. Could we look into that? She said, it's not that because you don't have any cysts. And, you know, people get on the internet these days and they think they're doctors. And let's just focus on you losing weight. And then we'll see what we can do from there. And I remember just leaving and feeling so dismissed and dejected and back to square one. And when I had to go back to the doctor, she wasn't available. And up until that point, I didn't know that you could say, I'd like to see someone else. And that's what I did. And when I saw the other doctor, I asked her, do you think there might be anything with this PCOS? And her response was, you know your body better than I do. Let's look into it. And it was discovered that I not only had PCOS, but after a hysterosalpingogram, which I think I'm pronouncing properly, an HSG test, we found that both of my tubes were completely blocked. And that at that point, years had gone past and no one had helped me find out what was going on with the periods, what was going on with PCOS, what could be causing any of these things. I had been diagnosed with hypothyroid when I was younger, but no one explained to me what my thyroid does or any other things that could have helped me feel less like an anomaly. During that time, we also pursued adoption. We looked into we served as foster parents. And then finally, 10 years after we got married, we were able to pursue IVF. We applied for a grant through the K Foundation. We were able to receive that, and we had our son Judah in 2016. After having my son, I experienced postpartum depression and anxiety, and my research librarian led me to find out that actually people who had experienced fertility treatments or who had experienced fertility issues at all had higher rates of postpartum depression and anxiety. And I realized that the mental health and the mind-body connection was also something that had not been included in the conversation. So from there, I've continued to advocate, because each time another layer was revealed, the more I realized that there had to be a bigger conversation had with my people, but also with all people, about what really entails infertility. So there were some clues that, like I mentioned, could have helped me feel like I was, not crazy. So understanding what hypothyroid was, understanding how that was a connection to polycystic ovary syndrome, whether or not I was actually ovulating, and did I even understand what a period was. These are things that most patients don't know to ask. We don't know that you can ask for another doctor. We don't know what we don't know. And so I also realized that medical literacy was another area where we're disproportionately given the information and access to the information, and that there was historical context for that as well. So one thing that I tell people all the time is that it is bigger than babies. When we hear infertility, we instantly think, well, once the person has the baby, they'll be fine. Or this is just about someone wanting to get pregnant. What we don't think about is that what is actually happening is a constant crisis of faith, finance, relationships, mental health, your job, your culture, your community. All of these things are happening concurrently while you're trying to navigate a major health decision at the same time. So many of the barriers to access that I discovered on my own journey that have been amplified from me meeting and talking to so many others along the way are these. So there is a cultural history of valid medical mistrust in the Black community. There is institutionalized racism throughout this country, but it does have its place in the medical profession as well. Health equity is an issue. And then, as I mentioned, a lack of medical literacy, understanding what our diagnoses mean, understanding how to look at and understand test results, understanding even how to make phone calls and ask for follow-up information is something that I was finding from other patients, that they were just not sure what to do and where to start. Understanding how to talk to their insurance companies about what was and wasn't covered, another area that many of them did not know where to start. And I live in Chicago, so I'm in Illinois, a mandated state, and I'm constantly getting people here who are contacting me in tears about insurance because they don't even know that what a mandated state is. Environmental factors and geographic redlining, and then the cultural stigmas of, well, we don't need any help to get pregnant. We actually need more help with contraception, and we have too many kids, and all of those stereotypes that we've seen of welfare mother, teenage mother, deadbeat dad, all of these things that culture has consistently portrayed about us some of us have started to believe and not understand that none of that is true and that there is far more to the story than what we've been told. So from historical context, and I won't get into all of these because I don't have as much time, but the things that I've researched that I try to make public knowledge through my organization and my blog and just in talking to people are these ideas of our valid mistrust of medical anything. So Betsy, Lucy, and Anarcha were enslaved women who were they were the patients of J. Marion Sims, who is thought of as the father of gynecological medicine because he is who performed the first successful surgery for vesico-vaginal fistula. However, it was his medical experimentation on these enslaved Black women that led to those medical breakthroughs. These women were treated without anesthesia, and in many cases, not only in the case of these three women, but in many other cases throughout history, access to Black and brown bodies through the slave owner was a way that many medical students and physicians could practice their skills. And this was often without the consent of these people or the full understanding of what was happening to them in their bodies. Henrietta Lacks, 31-year-old Black woman who had cervical cancer, and her cells were used without her permission, including the forerunner of what is now IVF. All of those things were done with the use of her illegally used cells. Ophelia Settle Egypt, who was a social worker in DC. She's actually one of the people who is credited with uncovering the Tuskegee syphilis project, which I'll get to next, but she was an advocate for reproductive justice because through her work with young mothers in DC, she found that she was receiving all these reports of Black families with too many children and that we were hyper fertile. And what she actually found out by speaking to the women was that they had no understanding of contraceptive care, no idea of where to go, and that in many cases, the male partner or husband had been forced to leave the home because it would make a barrier for them to have access to financial support. So here you are with no access to a way to not get pregnant. And then the more children that you have, the less access that you actually have to resources to help take care of them if they're the man in the house. And then the Tuskegee experiment, which many people know about, where Black men with syphilis were monitored rather than treated, and they were not given full understanding even that there was a cure for syphilis at the time or a treatment for syphilis at the time. So when you look at all of these things, there's lots of reasons why historically we don't go to the doctor with a trusting partnership mentality. It also goes to this idea that we are hyper fertile and we don't need to go to the doctor for this. We are told that if you go and you're doing something like IVF, that it is against your faith. We have very strong faith ties in the African American community. And we're also told, well, what are they going to do with those cells if you go in there? What they going to do with those eggs if you freeze your eggs? How do you know they're not going to do anything with that? So all of those things are running through Black patients' minds in terms of what to do and how to even get started. And then when we talk about access, this is Chicago, my beautiful, wonderful city, which is one of the most segregated cities in the United States. This is Chicago by race. These are the fertility centers in Chicago. There's one down by the South Side where I live. So for Black people to pursue treatment, we have to go outside of our neighborhood. We have to go in areas where we may not feel welcome or safe. We may not even know those areas or have access to get to them outside of public transportation. So those are additional barriers, and also ones that I was struggling with as well. Where do I go? How do I start? What do I do? How do I even decide which doctor to go to? Here in Chicago, we also have food, pharmacy, and postal deserts. So when it comes to my fertility medication, if it wasn't mailed to me on time, that could throw off my entire procedure. However, here in Chicago, we're dealing with the fact that we have some of the 4 worst performing mail locations in the Black neighborhoods. Many of our pharmacies have been closed. Many of our grocery stores have been closed. All of these things add to our lack of access to care. And then there's the mental component. So there was a study this year actually released that was called Tailored Support May Reduce Mental and Relational Impacts of Infertility on Infertile Patients and Partners. And it dealt with some of the things that affect the body and the mind when it comes to actual patients. 60% believed that their treatment was affecting their mental health, but only 44% sought mental health support. The number 1 emotion that patients mentioned was anxiety. 1 in 3 indicated that their relationship had suffered. Sadness, shame, isolation, fear, all of these things are factors. Access to care, in my opinion, includes fair and adequate education about our reproductive health and our diagnostic options. And to me, that includes cultural competency and the invitation to authenticity by patients. So one of the things that I have also mentioned is when we do go outside of our normal neighborhoods to get access to care, and we walk in there and nobody that works there is Black, none of the magazines have any person of color on them. Everything on the television doesn't include us. It tells us 2 things. It says, I can't afford this. And it says, am I welcome here? And those are things that people with the ability to make changes should be made aware of and should be cognizant of when they're making decisions. So I focus on how to change the conversation. So one of the things that I do as an advocate now are things that, most of these are things that I learned in my own journey. And I've just done those things for other people that I wish someone had done for me. So normalizing talking about reproductive health, even with younger family members and children. I talk about periods with my goddaughters and my nieces because my periods were ridiculous in high school and nobody talked about it. I didn't know what endometriosis was, what fibroids were, what PCOS was. The more that we talk about these things, the more that people know their own family history, and that helps when they go for those workups and they can get to the root of things faster. Taking control of your own health, going to our checkups, treating our bodies as valuable things, remembering that there are options, egg freezing, in vitro, egg donation, all of these things, and taking the Black people don't do that conversation off of them. The pen, pad, plan is my 3P method. So learning in terms of medical literacy, how to go to every doctor's appointment with a pen, a pad, and a plan. Writing down what I want to ask, making sure that I know that I can tell them, I didn't understand that, can you slow down and repeat yourself? Having a friend either with me there or on the speakerphone who can help advocate for me when I'm not strong enough to advocate for myself. Advocacy, supporting organizations that focus on reproductive health topics, events like this one, encouraging people to attend them. I spread this information through my sorority. I make sure that it's included when I talk to people at church, because all of these other areas affect the patient experience. I'm a member of Zeta Phi Beta Sorority Incorporated. We hold baby showers for the March of Dimes where we support young mothers and we talk about prematurity. Well, for someone who's dealing with infertility, those are hard events to be in. So I've tried to make it my business to include this conversation when we're talking in chapter meetings, because I want members to understand you're not alone and that we can start incorporating this into everything we do and try to make it a peaceful place for the people that we love and know, who we may not know are dealing with this. Same goes for our faith-based institutions and at work. And then putting our money where our hearts are, working with organizations that are already doing this work and making sure that that work gets to the people who need it. And then this is just a few of the amazing organizations that are Black woman-led and centered, that focus on infertility, endometriosis, miscarriage and loss. The K Foundation and Fertility for Colored Girls and Broken Brown Egg offer funding options for people to support them in their fertility treatments. And I encourage people to not only reach out to these organizations, but for support, but also to invite them to come and speak, invite them to be a part of, your next girls trip, invite them to be a part of the conversations that we're already having, because 9 times out of 10, what I learned when I was dealing with this so intensely was that the minute that I opened up and started saying this is what I was dealing with, 5 other hands went up that said, yeah, me too. And so the more that we talk about it and normalize it, the better we make it for everybody. And so that's me. I look forward to answering any questions that you all may have. I hope that was helpful of understanding the patient experience of infertility. And I look forward to hearing the next presenter, Dr. Desiree McCarthy-Keith.
Good afternoon, everyone. And I just want to say thank you again for this forum and for allowing us to present on this topic. I share the passion, and I'm going to get my screen together. I share the passion of Dr. Butts and Ms. Townsend regarding just the disparities that we face regarding our fertility experience. And so I'm happy to be here. I really enjoyed the presentation just now, giving us the human and the patient perspective, and I'm going to take it back to the science perspective. So everybody bear with me. My disclosure, I am on the medical advisory board of Progeny, which is a fertility benefits company. I have no information on Progeny in the talk. Before starting, I would like to just go back to the basics. When this is just a diagram of the menstrual cycle, and we really need to, I'm speaking on management of infertility today. So before I jump into what we do, I want to just review the menstrual cycle, because all of our fertility treatments either enhance or overlap the natural menstrual cycle, or we replicate this process through the treatments that we provide. So what you can see on the left side of the graphic here is that day 0 or day 1 is when a menstrual cycle begins. At that point, there are multiple follicles or eggs developing in the ovary. And every cycle, even though one egg develops fully and ovulates, there are many follicles that start to form. And then one of those will be selected to continue. That selection is primarily made by this green line of the follicle stimulating hormones. You'll hear this again, but FSH is a hormone produced by the pituitary gland in the brain, and it stimulates one of these follicles to develop and to ovulate. You can see that as a follicle is developing, estrogen or estradiol level is increasing from that developing egg. And then we also see this blue spike here is your LH or luteinizing hormone. And this is the trigger that tells a follicle that it's time to rupture and ovulate or release that egg. When women are doing home ovulation kits, they're measuring for the LH hormone in the urine. You get a spike in the LH, and then the LH is going to fall again. In the second half of menstrual cycle, progesterone production increases, and that's the purple line here. As the ovulated egg is released, there is an area left behind in the ovary called a corpus luteum, which produces the progesterone. As the corpus luteum kind of shrivels here and turns to a little smaller structure, progesterone level falls, and that drop in progesterone is what stimulates the endometrium or the uterine lining to break down, and that's what triggers a woman to have a period. If there is a pregnancy hormones maintain the corpus luteum so that progesterone production continues. You don't get this drop, and you don't get a menstrual cycle. I want to review just natural conception, and we go from ovulation to implantation. So again, there are multiple eggs or follicles that develop in the ovary every month, and naturally one of those may ovulate. You can see the proximity of the ovary to the end of the fallopian tube. So uterus and tubes are out to the sides. When the egg is ovulated, if the fallopian tube is open, the egg enters the fallopian tube at the end. At the same time, if intercourse occurs at the appropriate time, or if an insemination is performed, sperm will need to travel through the uterine cavity, down the fallopian tube, and it interacts with the egg in the tube. Egg is fertilized in the tube here. And just a side note, this is how and why ectopic pregnancies develop. Every time an egg is fertilized in the body, the embryo has to move through the tube. And if an embryo or fertilized egg gets lodged in the tube, then that's how a tubal pregnancy develops. Naturally, the egg will be fertilized here. And then in the next graph, you see the embryo is going through the stages of development. And as it is developing, is moving back through the fallopian tube into the uterine cavity and ultimately implants here about 6 days after the egg is fertilized in the tube. So again, when we conduct fertility treatments, we are either enhancing this process in the body or we're replicating this in the laboratory. When we enhance the process in the body, we often use oral agents or oral medications to stimulate those follicles to develop in the ovary. And the two medications that we prescribe are either clomiphene citrate or letrozole. Both of these act through the pituitary gland to ultimately stimulate a follicle to develop. Clomiphene citrate is in a class of medications called a selective estrogen receptor modulator, which means that the clomiphene binds to estrogen receptors in the brain and alters that signaling to the brain, which gives the signal that the estrogen level in the body is low. The way that the brain reacts is that it increases secretion of that FSH and LH from the pituitary gland. And as we saw in the menstrual cycle graph, FSH is needed to stimulate a follicle to grow. So that is the end result, follicular development in the ovary. Letrozole is another oral agent which acts in a different way. It is in a class of medications called an aromatase inhibitor. Aromatase is an enzyme in the body that converts male hormones into estrogen. And so by blocking or inhibiting that aromatase activity, estrogen levels for a short time will decrease. Again, that sends a signal to the pituitary gland that estrogen is low, and the response is an increase in FSH and LH secretion, which ultimately is going to stimulate follicular development in the ovary. When we use oral agents, we either use them for ovulation induction or for ovarian stimulation. For women who have irregular cycles or who do not ovulate normally or skip months without a cycle, we use these medications for ovulation induction, which means that we're trying to stimulate one follicle to develop, just to develop on time. For women who are ovulatory and who are already having regular cycles and developing and ovulating one follicle on their own, we can use these same medications for ovarian stimulation to stimulate multiple follicles to develop. We still have to be very careful with these agents because more than one follicle can develop. And if several follicles develop, that can increase the risk for a woman to have a multiple pregnancy, which we know can be higher risk. As I mentioned, these medications act through the pituitary gland in the brain. And so in order for them to be effective, a woman has to have an intact axis between her hypothalamus in her brain, her pituitary gland, and that communication to the ovary. These agents may be combined with either timed intercourse around a woman's expected ovulation, or they may be combined with intrauterine insemination or IUI. IUI or intrauterine insemination is a procedure in the office that we perform where we can place sperm in the uterus and giving them a little bit of a head start towards an ovulated egg. When we perform an IUI procedure, it is an outpatient procedure, very similar to a pap smear, no anesthesia, takes about 5 minutes. There's no downtime or restrictions after the procedure. With an IUI, a washed sperm sample is used. We always have to wash a semen sample because when you inseminate, we are only placing sperm in the uterus, and we have to extract the sperm away from the seminal fluid and the other components that are in semen. Those components never enter the uterus. So if a woman has intercourse, semen is deposited in the vagina, and the sperm then leave the seminal fluid and just sperm move into the uterine cavity. And so with an IUI, we are washing the sperm and extracting those sperm and placing them here. With the IUI procedure, a woman's placed in stirrups, just similar to a pap smear, and a speculum is placed in the vagina. We can draw up the sperm sample through this catheter, which is a fine catheter, maybe about the size of a spaghetti noodle. And we pass that through the cervix, and we just place or deposit that sperm sample at the top of the uterus. We are not directing it to one side or the other, but we're placing it here, and then the sperm will travel through the fallopian tubes to where the ovulated eggs are waiting in the tube. Indications for insemination may be if there's a mild sperm factor, where the motility or morphology of sperm may be slightly decreased, then this may enhance by giving those sperm a head start and getting them closer to the ovulated egg so they don't have to travel as far. We often perform IUI with couples who have unexplained infertility along with one of the oral agents, again, to enhance this process. Women who are using donor sperm would also undergo insemination. We first receive a frozen sperm sample from a bank. We thaw the sample, which may be washed prior to freezing, or we wash afterwards and can inseminate there. Again, IUI is minimally invasive. It's one of the less expensive treatments that we offer, and it can be combined either with ovulation induction or with ovarian stimulation. This is in contrast to in vitro fertilization, or IVF, which is shown in the graphic here. So in vivo, or in the body, again, the egg is released into the fallopian tube. Fertilization happens in the tube. The translation of in vitro is under glass or in the laboratory. And with in vitro, we replicate this fertilization process in our lab, and we monitor embryo development there. Indications for IVF may be if there is a more significant or severe male factor where male sperm count is very low or the sperm are less active, and we do not believe that sperm would be able to travel through the uterus and down the fallopian tube to an ovulated egg. Also, men who've had a vasectomy may have sperm extracted, and then we can use those frozen sperm samples in the laboratory, and I'll show fertilization with that in a little bit. Tubal factor, like Dr. Butts mentioned, is common for us and for Black women, and so if there are blocked or damaged or even removed fallopian tubes, or if a woman has had a tubal ligation, then IVF is a treatment option for that. We may begin with IUI treatments, and if we're not successful after a few rounds, then we may progress to IVF in those couples. Single gene disorders such as sickle cell anemia or cystic fibrosis may be screened for through the process of IVF, where we can actually take the embryos into our laboratory and look for that particular disease in the fertilized egg or embryo, and then prevent the patient from carrying an infected embryo and child. Also, women who are of advanced maternal age may undergo IVF for the benefit of, again, testing embryos in the laboratory first, not always for a specific gene disorder, but we can also test an embryo for the chromosomes and can know if it is a chromosomally normal embryo, which would lead to a higher chance of pregnancy. In contrast to the oral agents, medications for IVF are injections, and these are higher doses of FSH and LH that are given by injection. The patient administers these medications herself, or someone gives them to her at home. The average time to take the injections is about 10 to 14 days, so almost 2 weeks of daily hormone injections. They are injected through a fine needle under the skin of the abdomen or the front part of the thigh. And the goal of these medications is to stimulate multiple or numerous follicles to develop at one time. How many follicles develop depends on the reserve of the woman. And so again, we're sometimes see 10, 15, 20, or 30 eggs develop at one time. Along with the gonadotropins to stimulate the follicles, a woman will also administer another medication to prevent ovulation. As I mentioned in the curve, LH spikes when a follicle is ready to release. And so we have to give another medication to suppress that LH surge. Lastly, once the follicles are developed, the final medication is given, and it's called a trigger shot. This is the final preparation and maturation of the egg within the follicle so that it's ready to be extracted. And the medication we use to trigger are either HCG or leuprolide. After 2 weeks of injections, the ovary will contain multiple enlarged follicles or cysts throughout the ovary here. To extract the eggs from these follicles, a woman is placed under anesthesia. We perform a vaginal ultrasound and attach a needle to the ultrasound probe. This is a view of the ultrasound probe, and this is the shadow of the needle. So as the procedure is performed, we can watch the needle go into one follicle. We drain it through the needle. The fluid is removed from the follicle, and the microscopic egg is extracted along with the fluid. We withdraw the needle and go into the next follicle, and we're draining follicles one at a time and extracting microscopic eggs from each of these. That procedure takes about 25 minutes under anesthesia. Partner or relative or friend will drive the woman home. She rests that day. She may need a day after to recover, and then she gradually gets back to her normal routine after that. Once the eggs are extracted, we have 2 options for fertilizing or inseminating the eggs. The conventional insemination would involve having a fresh sperm sample from a partner that we would combine and incubate the egg with those sperms. So this is 1 egg cell, which is massive compared to all these sperm cells that are here. And so if you look closely, you can see this is the head of a sperm and there's the tail. So these are lots of sperm that are kind of surrounding this egg, and one of those sperm will actually penetrate and fertilize the egg. Our other option for fertilization is called ICSI, which stands for intracytoplasmic sperm injection. We perform ICSI if there is usually a sperm factor, or if we're doing the single gene testing for a genetic condition that may be passed on. With ICSI, we would look at a sperm sample under a microscope, select 1 sperm, and inject it directly into the center or cytoplasm of the egg. Once sperm and egg are combined, they are incubated, or they're combined in the incubator. We monitor as they develop into embryos. When the day after sperm and egg are combined, we look for these 2 features. So this is called a 2 pronuclei. These 2 depressions in the center of the embryo are the nucleus from the egg and the sperm. And if you see 2 nuclei, then you know that this egg has fertilized. If you see 0, 1, or 3, or anything other than 2, that's an abnormally fertilized egg, which would be discarded. Once this single egg fertilizes, it's going to split and divide a few times so that 2 days later, there's 4 cells. 3 days after fertilization, there's a cluster of 8 cells or so. And these cells continue to develop until they become a blastocyst on day 5. This area here is called the inner cell mass, and that's what develops into the fetus. The scallop cells around the outside are the trophectoderm, which becomes the placenta. We transfer embryos when they're at the blastocyst stage of development, and allowing them to culture to this stage will help us to see which are the best and most well-developed embryos that have the greatest potential for implantation and pregnancy. There are risks to IVF. They affect less than 2% of patients going through, but there can be hyperstimulation of the ovaries, and there can be physical and hormonal effects related to that. The ovaries enlarge with the IVF stimulation, and they can torse or twist, and that can cause acute pain, and in some cases may need to be relieved with surgery, but not very often. There can be procedure-related complications with anesthesia, self-administering medications, the extraction procedure of the needle into the pelvis and ovary. There's currently no evidence that fertility treatments that we perform with IVF or even the oral agents increase the risk of cancer or have any impact on a woman's future fertility. Just in general, for fertile couples to get pregnant naturally, chance of pregnancy is about 20 to 25% per month. And so you can see the comparison of pregnancy rates here by different treatment types. In a natural cycle, again, close to 20%. If we use the ovulation induction, we're again close to 20%. Super ovulation or ovarian stimulation combined with IUI brings us to the average fertility, is not to take us beyond or further than that. Pregnancy rates will be higher when you do in vitro and we bypass the fertilization in the body and we're placing a healthy embryo directly in the uterine cavity. Those pregnancy rates can be up to 65 or even 70%. Also, women who carry pregnancy from a donated egg from a younger woman can have higher chance of pregnancy than the average. Fertility preservation or egg freezing is another option for women who are not ready for pregnancy but want to keep their fertility potential at its current state. The procedure is exactly the same as IVF. The difference is that we stop when we collect the eggs and freeze. In order to utilize those eggs, a woman needs to return and complete the second half of in vitro with thaw of the eggs, fertilize with the partner sperm in the laboratory and let them culture the embryos there. There's a myth that women freeze their eggs because of career goals primarily. This evaluation of US Census data showed the opposite. Looks like partner and relationship factors are the greatest reason that women freeze their eggs, which is what I see in my practice. Professional is a consideration, and then there are other considerations below those. So how many eggs should a woman freeze in order to have a favorable chance for pregnancy later? Since every egg that's collected does not result in a pregnancy, it's recommended that women up to 37 freeze at least 15 to 20 mature eggs, and women over 38 freeze at least 25 to 30 eggs. How many cycles would it take to achieve that? What we know is that the average for a woman up to 40 years old with normal egg reserve is going to have maybe 13 mature eggs collected per cycle. And so she may need to go through 2 cycles to reach that 20 mature eggs. And similarly, for women whose target is 30 mature eggs, many of them will require 3 cycles to achieve that, and some may require 4 or even 5. The reason that more eggs are needed is because there is an attrition from the eggs that we collect and freeze to the embryos that develop ultimately. And so what we see here on the left side is that for women under 38 years old, when her eggs are frozen, we have to thaw those, and about 90% of eggs will handle being frozen and thawed before they're combined with sperm. Or the eggs and sperm that are combined, about 75% will fertilize. And then 1/3 of those will develop into a high quality embryo. So starting with 10 eggs, we expect possibly 2 high quality embryos from that. And what you see is that these percentages change a little bit as we get closer to 40. And so we need more eggs to still get to that 2 high quality embryos at the end. I'm going to think that I have a little bit more time, so I'm going to go through a little bit more of this. We looked at our pregnancy outcomes with frozen eggs, and what we see, just big picture, is that women who freeze when they're younger have the highest chance for having a pregnancy from their frozen eggs. The bottom curve is women who are 41 to 42. And so if we're freezing eggs or pursuing fertility, the younger, the better. Probability of having a child, again, you can see younger women have a higher probability compared to women who froze in their 40s, over 40. Eggs and embryos may be stored indefinitely, long-term storage in liquid nitrogen until they're ready to be thawed and fertilized or transferred to the body. Surrogacy is another treatment that is available for women who are unable to carry a pregnancy on their own. Indications may be an absent uterus, a significant uterine abnormality or anomaly, physiologic or medical contraindications to pregnancy, or a biologic inability to carry a child. This is all regulated by the FDA. There's legal and psychological counseling, which is provided for all parties when we go through third-party treatment. Egg donation is also third-party treatment, which we offer. Egg donors in general are women who are under 34. They may be anonymous to the recipient, or they may be a younger relative or friend and known to the recipient of the eggs. They're young women with normal ovarian reserve. They are screened by the FDA standards. They have genetic testing and screening for genetic diseases they may pass on, and they also undergo mental health screening. Recipients of donor eggs are usually women who have decreased ovarian reserve themselves, or they may have had unsuccessful treatment with their own eggs. There's always medical evaluation of the patient and the couple, and mental health counseling is very important for any third-party treatments. In general, fertility treatment cost, depending on what part of the country you're in, IUI can range from $500 to $4,000 per cycle or per month. IVF cycles between $20,000 to $25,000 per cycle. When you include the cost of treatment plus legal and compensation of a carrier, gestational surrogacy can range from $100,000 to $200,000. There are many income-based discount programs. Many fertility clinics offer military discount bundles or refund programs. And then, as Dr. Butts mentioned, insurance. I won't go over this again, but majority of states in this country do not have infertility coverage by state. I'm just going to go through just briefly outcomes for Black women. We do fare not as well compared to our counterparts. We require higher medications. Our implantation and pregnancy rates are lower, and we have higher miscarriage rates, and our live birth rate is also decreased compared to white women. We evaluated this at my practice, Shady Grove Fertility, and these disparities played out again. The largest disparity up front is that in this study, there were 4 times the number of white women who went through in vitro in our center at the same time as Black women. Our most common fertility diagnoses were tubal factor, decreased ovarian reserve, and uterine factor. We also were more likely to have high BMIs in the overweight or obese category, whereas white women had the highest percentage in the normal weight category. And we know that all of this affects our clinical pregnancy rates, our live birth rate, our miscarriage rate. So in summary, we have many fertility treatments options that are available to us. Women should consider freezing their eggs if they're not ready. The younger, the better. And we know that there are numerous ethnic disparities which impact our reproductive health care, and our experience. And so we always advocate for women to be proactive about their health and to seek treatment and look for people who they're comfortable to seek care with and who look like them and who understand their story. This is my contact information, and thank you again for the opportunity to be here.
Wow. Maybe if somebody explained it like me, I would have gone into REI. What a great job that you guys have done. I really appreciate that. And so I get the honor of sort of going through the question and answer. And I want to start actually with a personal story. And that is that you never know how things come to be, because this was just very fortuitous that we're doing this. And I have a family member who had really bad endometriosis. So she had like a 14-centimeter cyst. And the recommendation was to take the cyst out and then get pregnant right away. And actually ended up doing IVF. It was very successful. And then, of course, like after the baby comes, she gets pregnant automatically on her own. And then through a series of a lot of this is referral based on friends, right? So a friend of a friend, and they actually ended up going to a resident of mine. So long story short, I get this phone call middle of the week from someone who, from my nephew, right, saying that I want you to talk to my friend because they think that they're infertile. And I talked to them and they're 33. She just got off the pill. They've only been trying to get pregnant for 3 months. They don't have any risk factors that I can appreciate. But their biggest stress is that the family they've been married like 6 years and the family's saying, we're the kids, we'll pay for it, right? So I, said, look, you guys need to just stop stressing out and go have sex for fun. And then, you know, I get your anxiety based on your age, but if in 3 months you're still anxious, you know, call me back. And about 2 days later, I woke up and I said, you know, it took a lot for them to reach out to me and for a referral based on the thrill of knowing that they knew this cohort who had gone to somebody and that it worked. And so I ended up saying, you know what? I texted them 3 numbers of people to go to. I said, you know, you don't have, you know, whenever you're ready, just so you know, you have these numbers. And I gave them 3 numbers and, you know, 2 women and a man, just in case, because some people want to deal with a man. And because I thought, like, you know, 1, I didn't really see them as a formal referral. And 2, I guess my summary is that everything I heard today made me realize that what I did in the middle of the night was the right thing. That if they felt they needed to see somebody, they probably needed to see somebody. And so, and I think that what I learned today is that we don't need to be gatekeepers. That what we need to do is make sure we're giving out information. And so the information you shared today was excellent, and I thank you. And I am now going to moderate with some questions. And one question I want to start with is, and maybe we'll go back and forth since I think you guys are equally qualified, unless it was specific to your talk. But I'm going to start with Dr. McCarthy-Keith, just because you were dealing with treatment. Can you address concerns that people have around, and it may or may not be a myth, but I'll let you decide, that taking birth control impacts subsequent fertility?
That's an excellent question. It does not. And so, you know, there is a cycle of follicles and eggs that pass through the ovary. And what many women don't appreciate is that we are born with all the eggs we have. We are so different from men in many ways, but men make fresh sperm from scratch on a cycle of every couple of months. And they do that until they're 50, 60, 70. And so we see men who are fertile at those ages. But each woman, we have the most eggs when we're still in the uterus. 20 weeks pregnant, we have 6 or 7 million eggs. By the time we're born, we have 1 million left. We've gone through most of our egg supply in utero, and so we keep drifting down from that 1 million from there. And every month, there's a whole wave of 50 plus eggs that start to grow. One may ovulate, the rest of them fall back. Birth control pills or pregnancy, puberty, none of that changes that. There's a wave of eggs that pass every cycle, and we're just constantly losing. And there's nothing that we can do to save them. So sometimes women will think, if I'm on pills, I'm holding my fertility, I'm saving my eggs because I'm not ovulating. They're passing by. And so it doesn't, birth control doesn't decrease our fertility, but it doesn't hold on to it or preserve it either. It's a natural process behind the scenes that we all just need to be aware of. Egg reserve is changing, and so we should just be proactive when we're ready, or at least have a plan, like Regina mentioned.
In a little bit.
Dr. Butts, how do you know if you have fibroids?
Yeah, it's a great question. And I knew I was putting fibroids out there. You know, this whole, we could have a 2-hour webinar on fibroids alone. Before I answer that, I want to just tag on to what Dr. McCarthy-Keith answered, which is this. A lot of times people are placed on the pill for reasons that impact their fertility, but nobody's discussed it with them, right? If you're placed on the pill when you're 16 years old because you have irregular heavy periods,
Yes.
maybe somebody should have tested you for PCOS then. And then you come off the pill when you're 32 years old and you want to have a baby and you're like, the pill did this to me. No, it didn't. The person who didn't diagnose you and work you up properly when you were a teenager could have shed some light on this. And also giving you the tools to be more proactive so that when you came off the pill at 32, you weren't having a nervous breakdown and you knew that you had to be more proactive. You know, like the things that we give people the pill for is not just contraception. It's for really bad, terrible pain with their periods as well. So I just wanted to add that in. And while we're on the subject of heavy painful, terrible periods. I'll talk a little bit about fibroids. I mean, a lot of the outstanding questions that I saw in the Q&A, like the person who answers that question is going to win the Nobel Prize. And I'm not trying to be funny. It's just a testament to the fact that there's a lot of really smart people working on these things. And this is a hard, difficult thing to get at. You know, fibroids on the one hand are incredibly prevalent. Your lifetime risk of developing fibroids for any woman is about 70 to 80%. But how those fibroids show up is very different in African-American women versus everybody else. The youngest person I ever operated on to remove symptomatic fibroids was 18 years old. And the only reason I operated on her when she was 18 is because she fell off the grid when she was 16 and was lost to follow-up, and she needed surgery at 16. Like, the severity, number, recurrence of fibroids is just a completely different, it's almost like a different disease in African-American women compared to everybody else. And I saw somebody's very astute question in the Q&A, which was, I heard that fibroids don't slow down their growth in African-American women, whereas in other populations, as you get older, they shrink. I would only change that to say yes. So I can't necessarily reassure my African-American patients that when you're 35, 36, 37 years old, that the rate of fibroid growth goes down. The rate of fibroid growth goes down in pretty much everyone else. So fibroids are not going to necessarily shrink while you're premenopausal, and they definitely won't slow down their growth. They are common, but very, very different in African-American women. And I think, you know, that understanding alone is reason enough for women of color who want to try to become pregnant to have conversations with their gynecologists early and often. And I'm saying gynecologists specifically, not that the primary care doctors don't have a role to play, because they do when we're talking about preconception health, but there are people who are walking around with significant but somewhat asymptomatic fibroids that should be known about maybe before they start to become pregnant. And you know, I tell patients this all the time, like, you should be as entitled. You should come and walk in here and be just as entitled. I mean, I used to work in Philadelphia, so my reference would be like, you should walk in here and be just as entitled as the ladies on the main line. And people would look at me like I had two heads. I'm like, okay, I will try something else. But you know, but like, that's our job, is to like make you feel like somebody who says to you, oh, stop going on the internet and thinking you have PCOS, right? Never talk to that doctor ever again. Never talk to that person ever again, period. Find another person. We wouldn't accept this from any other thing in our lives, right?
So that's a good segue, Ms. Townsend. Can you elaborate on scholarship from the K Foundation?
Sure. So the K Foundation isn't the only one, and the K Foundation doesn't only serve the African-American community. It's just led by Dr. Camille Hammond, who her mother actually carried her triplets when she was struggling with infertility. The K Foundation offers multiple grants. And in addition to them, there's also, like I said, Fertility for Colored Girls. And then also the Broken Brown Egg offers them one as well. What all three of us do is, it's an application process. Each of us has an advisory committee that usually has an REI or more than one REI on it that can look at more than just the financial need, but also what, you know, they are presenting as medically, to see if this money will help or is it something else that needs to be done. Because our biggest concern is advocacy and making sure that people understand the wholeness of it all. So even if someone can't necessarily get the grant that covers treatment, it may be, can I help you with your medication? Maybe you just need somebody to talk to. Maybe you didn't even need the treatment, but you didn't know that your state was mandated. So that's how, you know, a lot of us in terms of the advocacy work recognize, you know, that there's some other issues here as well, where we may have people who are so disconnected from the infertility understanding that they think this is unattainable, this is a white person thing, I'm not going to be able to afford this, let me apply for this grant. And then once we look at the application and actually see what's going on, we're able to call them and say, hey, actually, did you know your state covers this already? Did you know this is a place that you can go? And so aside from just offering the financial help, it's a really great resource in terms of support and understanding and community as well.
Great, thank you for that. Actually, this is kind of an interesting question, and I'm going to put it out to the panelists. What's your perspective on the recent abortion ruling affecting fertility treatments such as IVF?
Nobody wants to answer this. It's such a hot topic. What I will say is that I'm here in Georgia, which is historically red. Hopefully we're going to be blue next week. Hoping. It just caused so much panic and fear, and patients just really, all fertility clinics were inundated with, what does this mean for my care? What does this mean about my embryos? Am I going to have to move to a friendly state? Am I going to have to move my embryos? Things that are not founded at this point, but it just shows how vulnerable we are when our reproductive health is in the hands of other people. We're still functioning the same at this point. As specifically in Georgia, there's 6 weeks, and 6 weeks with a heartbeat is where the line is drawn for abortion services, and that's what's really focused on in the law. So we are still functioning, and clinics throughout the country are functioning, but again, it just highlights the vulnerability of all of us and just the stress that this ruling has caused for, couples who are trying, couples who've had pregnancy losses, couples who are thinking about their future. It's just very unfortunate.
Dr. Butts, do you want to add anything?
I would echo that. I really think it depends on the state that you're in. I'm in Pennsylvania. A lot of stuff up in the air based on things that happen in less than 5 days. And my counseling to patients has been, we're going to move forward with your care. IVF is not illegal. I've heard some things on outlets like NPR and other places that, the people who are coming after reproductive rights are never going to come after you guys because a lot of them have needed your services to become pregnant. So hypocrisy hasn't stopped politicians from doing stuff in the past. So I don't know about that, but I think we have to just move forward and offer patients the care that they need. I think we should also be mindful when we're doing treatments like IVF and having candid conversations separate of anything that's going on with Dobbs about the fact that these treatments can help you with your real-time fertility goals and help you with your future fertility goals. But we also have to be mindful of the fact that it's a very, very hard position to place patients in if they have many more embryos to work with than they would ever feel comfortable using to build their family, and have those conversations early about managing disposition of embryos, long-term storage. I think it's just more is more when having these conversations with patients.
Ms. Townsend?
I would just add from the patient advocacy side, this is another area in terms of literacy. In many cases, many patients, especially people of color, once again, we have to look at the elephant in the room, and that is that because of systemic and institutionalized racism, we don't automatically think, well, let me contact my senator and ask, how is this going to affect? We don't automatically think, can I go to, city hall, state government? What can I do? And so I say, in terms of patient advocacy, understanding that the people in office work for us and that you have the right to reach out to them, that there are Resolve and ASRM does an advocacy day every year where you can contact your state representatives and legislators and let them know your feelings about your fertility preservation and treatment options. Many cases, they may not understand how their feelings in terms of one issue affects family building in another area. In many cases, they may not understand, like Dr. Sam mentioned earlier, about cancer treatment. They may not even connect that someone who is a young person who's 16, who doesn't have any interest in getting pregnant right now, may need to know that they have the option for fertility preservation, because depending on their cancer treatment, that could be affected in the future. And in many cases, once a legislator is brought to their attention, sometimes you'll be surprised where they say, I had no idea. Thank you for letting me know. And so I would say from that side, advocacy and empowering patients to, take that as something that we can do is another part of what's important going forward. And I'm hopeful, because I try to look at the silver lining of things, I'm hopeful that many people, because of this post-ops environment we're in, started to look at things in the bigger picture as opposed to just the black and white. Because as I say all the time, it's bigger than babies, and we have to look at the entirety of a situation and how this is affecting more than just what we think it's affecting.
So there's a recent paper in the Journal of Pediatrics, and there's media talk about Black infants born by in vitro are 4 times more likely to die in the first year of life compared to white infants. Why do you think that might be true?
I mean, so this is building on a disparity that we've known about for a long time. I mean, I think maybe the hook that people are emphasizing is that, well, people who get infertility are probably like better off, more plugged in, more resourced, higher SES. And so we might expect that their children would do better if conceived after IVF. There's so much data that totally contradicts that. I mean, I can't give you the exact reference, but it has been published that Black women with a college degree and higher are more likely to have maternal mortality than white women with a high school education. So why is this a surprise? Why is this I'm not saying like this is just supporting everything we've always known. I don't know if anybody else wants to reply differently, but.
I agree. Yeah, I agree. And, celebrities, socioeconomic status, none of these things change that. We've seen many women in the media who have had, poor pregnancy outcomes and complicated pregnancies. Serena Williams and Chrissy Teigen, and women who you would say, well, they're in a different status. It doesn't matter. Black women do not do as well, regardless of our position in society, and that's unfortunate. And so I agree with Dr. Butts. This just highlights what we already know.
So I'm going to take moderator privilege on this question about Black women and hypertension and the medicines to avoid. And it's the ACE inhibitors, which are actually the drug of choice for a lot of Black people. But once you get pregnant, you should stop them. So that's a little preconception counseling there. There was another one here I thought was interesting. Egg freezing versus embryo freezing.
That's a good
So
one.
that's a great one. And, freezing eggs or embryos is a great option for women who, again, want to preserve where they are with their fertility, but not necessarily be pregnant. It's usually encouraged that if a woman has a partner, that you go ahead and freeze embryos, fertilize your eggs, and know the potential of those eggs. Because anytime you freeze your eggs, the reason that I showed slides of you need 20 and 30 eggs is because all those eggs don't make it to an embryo. And if we freeze your eggs, there is a pause and a question mark until you come back, which may be years and years later, for you to know the potential of how many of those eggs actually lead to a viable embryo and a healthy pregnancy down the line. So for women who are single without a partner, yes, freeze your eggs and then freeze as many as you can so that you can get to it when you come back to thaw those. But if you have a partner, a couple who wants to delay pregnancy, but they're committed and they have sperm available, it's recommended to go ahead and fertilize the eggs and know that you have developed and formed embryos waiting for you, and you have more better chance for success when you all the way to the end of that process versus stopping in the middle.
And I've also encouraged some of my single patients to think about freezing embryos with donor sperm as well. I mean, I just think it's like we don't put all the options out there, like, yes. And they look back and say, well, why didn't you tell me that I had the option of just buying some purchasing some donor sperm? and freezing it. So it's for the patient. People cannot accept or reject an option that's never been adequately presented to them. And so if they decide that like, that is not where my head is at, I don't want to freeze embryos because I'm still waiting for my future life partner, if that person comes along, that's for them to decide that they want to reject using donor sperm. But I've had patients who do one cycle, we freeze eggs, one cycle, we froze embryos. They feel comforted by that. And, no small task, obviously, but at least they've covered all their bases.
And how readily available is sperm that looks like us?
Ooh, that's a good question.
I
It's
love you
limited.
for asking it. I love you for asking it because I was just thinking it, and I love you for asking it.
Wasn't there something in the Times published about this recently, or some article?
Mhm.
So like everything during the pandemic, it's worse
Right.
than before the pandemic. It's hard.
It's limited. And what I tell patients is that just culturally and in our community, people who look like us are less likely to donate our sperm, our eggs, our bone marrow, or to go through these type of treatments. And so we do see that it's not impossible, but there are fewer Black sperm donors available. There are fewer Black egg donors available, but it doesn't mean that patients should be discouraged. It just means that you might need to go to several different banks before you find a donor whose profile you like, who is also Black, but it doesn't mean that they're not available at all.
And for those of us in an advocacy space, or just, I believe everybody is an advocate. Let's just be honest. Everybody is an advocate. The minute that you sit down with your auntie or your sister or your soror or whomever, you're already advocating. So one of the things that I also tell people is be more open about those conversations. Like, there are so many people who had no idea there was a Black male sperm shortage. And even in discussing, I've had a friend who said, I was interested in being an egg donor, but when I reached out to a company, they told me there was no need for Black eggs. Like,
That's the opposite.
yes, exactly.
Wow.
We need them.
Have to be
So-
had so that she would know, oh, next time somebody tells me something like that, I can say, actually, that's not true. And I need to go to another place. And then
Yes.
also going back to that cultural piece where historically we have not felt safe donating or sharing or any of those things. So when we look at that and we make people aware of it, then we can talk about what the differences are between informed consent and understanding what's happening and understanding in terms of being a known donor and all those other nuances that just sound crazy and foreign to us. Once we actually get to the root of them, we can help turn this thing around, hopefully.
So on a similar to the birth control question, does the number of abortions increase infertility?
This was asked, I think, more than once. Somebody asked it like if it's done by a trained professional. I'm never going to sort of sit on a panel and say that women who need abortion care should not access it. I think having the care provided by somebody who is reputable and experienced and knows what they're doing is important, and having adequate follow-up afterwards to talk about, what, again, that first question I asked, what's your reproductive life plan? Right. And by the way, let's make sure you didn't have any like infection complications from this, but like to have that happen and then nobody follow up,
Right.
Yeah. So I think, it depends.
All right, so I need to remind everyone to take the survey evaluation. There'll be a QR code at the end. There'll also be contact information for both Dr. Samantha Butts and Dr. Desiree McCarthy-Keith and Miss Regina Townsend for follow-up if there's any, as well as I must make a plug that I am at Cedars. So if you guys want, there is a very comprehensive infertility program there. And to remind you that the next webinar will be the first quarter of next year, and it will be on Black infant mortality. So maybe we'll get some more answers to this. And then I'm going to take the last 2 minutes and ask everyone for a round robin parting shot. Like, what's your take home that you want people to remember? And I'll start with Dr. Butts.
So Dr. Gregory, there's one question in the chat that's offered up by a medical student that I met in a completely different forum through a Penn State virtual elective. It's Danae, and she asked the question about whether, as during my 10 years of Black REI, what misconceptions have I noticed within our community? How do I address misconceptions and thinking about sort of underrepresented patients and providers in infertility? And I think, you know, a lot of the things that we discussed, it's pretty heartbreaking that, you know, Regina was put through what she was put through, that patients, that we can't do better than this, right? We can do better than this. And I think it's like anything that matters, it's going to take time to fix it. But we have to keep talking like this. We have to make ourselves available. That last picture that I put up there, I was by design. I want people to see that Black doctors do this, right? Like, you know, we can do any specialty in medicine we want to. And there's a need for Black REIs, like there's a need for Black pediatricians and vascular surgeons and neurosurgeons and everything else. We should do anything in medicine we want to do. And then I think it's up to us to sort of pay it forward and reach back on all of those wonderful things that we can do. And you can see how small the world is, because somebody I met in August at a Penn State virtual OBGYN elective is now on this webinar, which I think is wonderful and beautiful. And I'll just reiterate what I said before, which is I'm so incredibly honored to be on this panel, so grateful to all of you. I mean, I'll come back every month if you want me to. We can, because this is not, it's not a one-off, guys, right? Like, let's just keep finding ways to have this conversation in different ways. But thank you.
Thank you. Ms. Townsend?
I just wanted to say I'm just honored to have been included. This is my preferred soapbox talking about this. I think once you open the door to something where you realize that your entire people are struggling with it and there's just not enough conversation, it's very hard to close that door. And I feel honored to, for one, have so many Black doctors to know, because it helps me when I'm speaking to younger people. As I've said, this is an intergenerational conversation that has to happen. And so it helps me to be able to tell them, do you know how many Black doctors there are, not just in one specialty, but in general, and helping them to understand that this is something that's attainable for us and that we can just talk, you know, to them. And then also I say it to all people that I talk to, is that it's bigger than babies. There are actual people behind these diagnoses who are struggling with all of the other parts of being Black while dealing with this. So in all of that time of dealing with my fertility issues, I still had to be at work and try to be better than everyone that was already there. I can't take days off because you don't want to look like the Black lazy person. I can't be irritated because I was tired, because we can't be snappy Black woman. I have to make sure that I'm doing the best and the best and the best in everything. And also that affects the frustration and anxiety of not being able to get pregnant, because I've been told that Black women need to excel at everything and that this is supposed to be easy and natural. So all of that is happening in someone's mind when they walk into the office. And because all of that is happening, they're not going to think to say, I didn't understand that. Can you slow down? I don't know what to do. I don't know where to go. And so this is bigger than babies. This conversation is about us as people and as a community, and getting back to that community mindset. And so I'm honored anytime I get to hear about this topic and talk about it, because I feel like this reaches back to our culture of storytelling and sharing and village mentality. So thank you for having me.
I appreciate that. Thank you. Dr. McCarthy-Keith, take us home.
Excellent. So I love this conversation, and I am so proud to have been a part of this panel. I think that this was fantastic. And what we really highlighted here is that the disparity for us exists, but we don't have to be defeated by our disparity. There are many factors that are modifiable. And so once we educate ourselves about these factors, we can work towards improving them. Age is a factor for ladies. Don't wait. we take too long before we seek care, before we go through our fertility treatments, before we freeze our eggs. And if we're freezing in the 40s, those aren't the best eggs to freeze. So think about our age. We can control when we jump out there, manage our fibroids if we know we have them, keep on top of them, have routine checks, and just keep in touch with your OBGYN. And if your fibroids are starting to cause symptoms, you need to have them looked at or have an intervention to keep them from progressing. And like I mentioned, our lifestyle, our weight, our diet, the food deserts, all of these things impact our general health, our chronic medical conditions, and our fertility. And we can control that by the quality and the types and the amounts of food that we consume and how active we are. So we can't change our genetics, but we can definitely change our lifestyle and some of these exposures to put us in a better position so that when we do go for fertility treatment, we are more likely to be successful. So always want women to just educate themselves, participate in these type of webinars, and be an advocate. Like Regina mentioned, we have to speak for ourselves and surround ourselves with a supportive village. There are many people who will say, Black people don't do that, and we, talk you down. Those aren't the people that you need in your village. You need people who have been there and who are supportive and encouraging us to take advantage of these technologies and treatments that are available to everyone. We shouldn't be missing out on this. And so I'm very passionate about it. Thank you for having me here. And it just makes me proud to be a part of this panel and this group.
Well, I
Dr.
echo
Gregory,
that.
can I say one last thing? This is going to be the best thing to end on. So the recently installed president of the American Society for Reproductive Medicine is a doctor named Dr. Michael Thomas. He is the first Black president of ASRM ever. He is a mentor of mine, and I'm sure to Desiree in some form, and Regina, I'm sure you've interfaced with him too. He's an outstanding doctor, an even better human being, and super, super proud to know him and have him lead our organization for the next year.
Absolutely.
Well, that's a great segue for my conclusion. One of the things that I really admire about ABWP, I was told my mom I'm giving a webinar today, and my mom always asks me when I go to meetings, were you the only one? And today I could say not only was I was not the only one, but I was in great company. So I am honored to have been with you. You have represented us all, as usual, 10 times better, because that's just who we are and how we show up. So bless you guys and have a great rest of your Saturday and weekend.
Thank you so much.
Right. And there's your CME information. I'd love to see you again sometime. Do you know Dr. Kim Lipscomb in Georgia?
Of course. Yeah. Yes.
She was my fellow. So we're
okay. Yes, I know Kim well.
I talk to her once a week on the way to work. So
yeah.
Okay.
Yes. She was a member of ABWP, and she was a president of ABWP.
Yeah.
So we all know her very, well, not
Absolutely.
like, but certainly from a long time ago.
Yes, good company as well.
All right.
Thank y'all so much. This was my pleasure and my honor to be here. Thank you.
Thank you so much.
Have a great day.
You too. Bye.
Bye-bye.
Thank you, Kim. Thank you. Well, there's Brandy. Who's left? Brandy and Noemi.
I'm here. I think our speakers have left, and we still have some participants that are probably just getting the information for the webinar link. I believe the evaluation link is also in the chat. And then of course you can.
Yeah, I saw it in the chat and I clicked on it. So I'm going to do